Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. This is an interesting day. This is the first time that we're using a studio in the Allen B. Levan NSU Broward Center of Innovation, which is an unbelievable venue which you will hear about over the next years and almost immediately, because it will be a center for innovation that will bring technology and new economy to Florida, not only South Florida, but Florida. But let me introduce to you our two guests. Our topic today is how to treat heart disease and arrhythmias. I couldn't ask for better two folks. So let me first introduce Dr. Fred Chaleff, who's a cardiologist. He's with HCA Florida Westside Hospital. Welcome again, Dr. Chaleff.
Thank you, Dr. Lippman. Pleasure to be here.
Back. You were a big hit the last time you were on.
Good to hear.
Yeah, and Dr. Satija, who's an electrophysiologist. Dr. Satija, welcome.
Thank you for having me.
Let's start with you, and we try to make it easy on people, but the reason why we do these shows is because we get a lot of questions. I was saying prior to getting on camera to Dr. Chaleff, this is a very interesting point. We're at our 555th show, which means that we've been going on for more than 23 years. So what we do is we take questions that come from the viewers. And there's a lot of folks that, they've been very kind to watch us. And one of the biggest items that have come to us over the last 2 to 3 months has been the issue of cardiac disease. I guess there's a lot of communication relative to the effects of the pandemic and things of that nature. I really don't know what has driven all of these comments. But we'll start with you, Dr. Satija. Tell us what an electrophysiologist is.
So I'm a cardiologist like Dr. Chaleff, but my specialty within cardiology is treatment of rhythm disorders. So that's patients with abnormal heartbeats, abnormal heart rhythms. That's both medical management of it as well as interventional surgical management of it, whether that's with a catheter or a pacemaker or a defibrillator. So I'm an electrician of the heart, basically. Dr. Chaleff is a plumber, and I'm an electrician. We often work hand in hand.
That's. I would almost say that's cute, but it's not, because you are a highly skilled, well-known cardiovascular electrophysiologist. So thank you very much for being here. Dr. Chaleff, as a cardiologist, in quotes, you do a lot of work with your colleague. Tell us, in general, what your field of endeavor is, and so that the people get to know, once again, who Dr. Fred Chaleff is.
So what I do is, I'm a cardiologist, of course, as you know, but I practice general cardiology and interventional cardiology. So like Dr. Satija says, he focuses as a subspecialty more or less as the electrical aspect of the heart. We do the coronary artery, structural, valvular heart components, and they both are very interrelated. And we talk frequently about these issues. And a lot of times, as a general cardiologist in my practice, patients will come to me, for example, with arrhythmias, atrial fibrillation or extra beats or palpitations. And then in some cases, I would refer to Dr. Satija for a pacemaker, ablation, or whatever the case may be.
Let me, again, I bring to your attention, my belief is that the reason we've gotten so many communications, of course, we've been through this period of now almost well over a year and a half of this insidious pandemic, which now is giving us information. I guess we get it from various sources as to what we call the after effects of someone who has had one of the viral problems. And a lot of it relates to also questions that we have from people. They want to know whether they should get booster shots. Let's talk a bit about that because they had a lot of questions about it. So, Dr. Chaleff, why don't we start with you?
Okay, well, first and foremost, the vaccine is extremely important. And we absolutely recommend a booster and a second booster if it's appropriate and a patient is at a high risk. Because we do know that complications of COVID and long COVID can be very detrimental. And I see patients complaining of numerous issues related to COVID. But we do recommend the booster, especially for those people that especially meet the CDC guidelines for a second booster. However, a lot of times we will check the titers of patients' blood to see what their immune response and how they responded or to, let's say, the COVID itself and or the vaccine. And we can see exactly where they stand immunologically as well. And this has become an important tool for us. But boosters are definitely important for the appropriate people.
Dr. Satija, why don't we get you in on this conversation? I know you have some thoughts. Go right ahead.
So I agree with Dr. Chaleff. The vaccines are very important. They've saved a lot of lives. Certainly, there's a concern that the immunization will start to wane over time, and that's the thought on the second booster. Now, it's important. The CDC is recommending it for older patients, over 50 with comorbidities. I think it's a very good idea for older patients. I would not necessarily recommend it for the really young men, 18 to 25. I think that's probably not necessarily the right thing, but for the older patients, I think it's important because as their immunization wanes, they can be once again prone to having a significant burden from infection. And unfortunately, I think we're still in this for the long haul. I don't think this goes away anymore.
I know that there are so many opportunities today for people who are qualified and knowledgeable as you are. Of course, we were kidding around by saying you're the electrician, but not really. When you do certain views of the heart and the actions of the heart, you work with your colleagues like Dr. Chaleff, and you remediate, hopefully, the problem. So, do you work hand in glove with the interventional cardiologist that Dr. Chaleff is? At the point in time when they are going to do, for example, a stent?
Yeah, that's a good question. So we all have our own niches in terms of what we do. It's certainly a collaborative team effort. Nowadays, we have general cardiologists, interventional cardiologists, electrophysiologists, structural cardiologists who do catheter-based valves, the cardiac surgeons. We're multidisciplinary. Now, when someone needs a stent, luckily that's a routine procedure. Dr. Chaleff or one of his partners would do that routinely, solo, because that's his routine business. Same thing if I did a pacemaker, that's usually what I would do just alone because it's routine. Whereas more complex cases, it's not that uncommon to be multidisciplinary. The other day I did a complex case at Westside, and I said, listen, I'm going to need a second pair of hands and somebody with a different skill set. And I had a structural interventionalist, a guy who does valves and other things through catheters. And he and I work together because we have different tools that we can both bring at the same time to treat the patient. And so and I think that's the way medicine is going. It's very common now that we say this is not just a surgical problem. It's not just a catheter problem. We're going to work together and figure it out together. And I think that collaborative approach is the future going forward.
So Dr. Chaleff, talk to us about how things have changed, not only because of collaboration, but because of new techniques and new procedural opportunities.
We used to first start, it used to be just a balloon that we used to put in to open up blockages. And then as technology evolved, we learned that, well, this was an issue because this was not long-term. There was what we call restenosis, scar tissue would develop. Then we developed stents. And when we put these stents in, and the delivery method, of course, evolved, but essentially the stents would go into the artery, inside the lumen, open up the blockage. But then this also had developed scar tissue at a higher rate. Although the vessel was a little more stable, there was still scar tissue. Then we figured out, okay, we need to put a medicine on the stent in order to prevent this scar tissue from developing. And then we did that. And then it was the type of medicines, the drug-eluting stents that we refer to, that evolved that gave us the best outcome. And then we had to determine with new technology what was the best antiplatelet therapy. When this first started, we would use something simple called Coumadin that many people know, and we realized that didn't work. And as we became more knowledgeable, we realized we need what we call dual antiplatelet therapy, that was the real mechanism to prevent clotting inside the stent. The stents got more sophisticated, the drugs that we deliver in the stent, the size of the stents, the catheters to deliver the stents, the medicines that we use to prevent this, the clotting, all evolved to where we are today. And yes, it's been a very rapid acceleration, but a real benefit that's happened with patients is what we see is patients who come in with what we call a STEMI, an ST segment elevation myocardial infarction, an acute heart attack. Now what we do is we try to bring them to the cath lab as soon as possible, try to open up that blocked artery and restore blood flow to preserve the heart tissue, the myocardium. If we don't get there soon enough, then it could be subsequent long-term damage, heart failure, arrhythmias, things of that nature. So the sooner we bring them in with this new technology, the quicker we can open up that artery, the less heart damage we have.
All of the athletic programs that we have at the university, and we're very proud of our athletic programs, we do a complete cardiac screening before they can even get onto whatever it is, the basketball court, the swimming pool, the football field, the soccer field, etc. Because we don't ever get the full knowledge spectrum from their medical past. And we do the screening. Do you see many, and I know we were jumping to another area, but do you see a lot of young people with cardiovascular problems?
I actually get patients with this. It's not common. These are rare conditions, luckily. But the preoperative exam and the preoperative physical for athletics sometimes will come up with familial inherited conditions that can be dangerous. I remember when I was a younger doctor, I had a gentleman who was a star running back in high school, was going to get an NCAA scholarship, and kept passing out. I diagnosed him with a rare inherited condition that made him prone to have cardiac arrest, to have his heart stop, and he needed a defibrillator. And that ended his athletic career, unfortunately. And we all know the stories of these basketball players and football players who die on the field or die on the court. And that's what we're trying to prevent. Those conditions are rare, but that's why student athletes, teenagers are getting screened to look for these things. And, the pediatric cardiologists see a lot of it. We see some of it in the adult world. And then when it gets bad, sometimes I end up seeing these because some of these can be very significant conditions.
That's a good point, because I know the screening a lot of times, especially in Europe, they actually do echocardiograms to look for structural heart disease, more common in Europe. And now I think we're starting to adapt some of that here to screen for those potential sudden cardiac death patients.
So my question to both of you is, how often should someone be referred or come directly to you, if possible, to get what I would call a cardiovascular checkup?
That's a good question. I think especially as you get older, if you have risk factors, high blood pressure, the diabetics, the obese, getting a cardiovascular checkup, especially as you reach middle age, is important. That's a lot of what Dr. Chaleff and his partners are going to do in their office, and he can talk about that more. But especially after the pandemic, we're seeing a lot of undiagnosed cardiac disease, because patients were doing Zoom visits or telephone visits with their doctors. They weren't getting EKGs, they weren't getting examined. And now we're getting really slammed with some very sick patients who had disease that didn't get screened for several years. Fred, you can talk about it more, I think.
It's absolutely true. They've been very sedentary. They weren't exercising. The typical patient that would come in with chest pressure would not. They say, oh, it's indigestion, when essentially it may be angina. And yes, we would do Zoom calls, but it's not the same. Like Dr. Satija said, you don't see the EKG. You don't listen to their hearts. And you can miss things with those Zoom calls. So we do like to see them in the office. It's more hands-on, and we can get the things we need to, and much quicker too. We have to set up for those stress tests, those echoes, those EKGs, the lab works. We didn't even know their cholesterol levels when they didn't come in. We didn't even know talk to them about their diets much. So yes, we are getting slammed with a lot of onset of progressive coronary artery disease. But I do want to allude to one thing that Dr. Satija can embellish on this. I've seen a lot of patients, not a lot, but many, in the hospital with COVID that actually have developed what we call atrial fibrillation and cardiac arrhythmias, and younger people as well. I just would like Dr. Satija to comment on that a little bit.
Right. That's my life's work. So that's what I think about a lot. And so certainly with COVID, we've seen a lot of atrial fibrillation. Atrial fibrillation is a common arrhythmia that you tend to see as people get sick, as they get older, as they develop other heart problems. But even in healthy people, you can develop it. And what we end up finding is these patients have irregular, fast heartbeats. They can be difficult to control. They can be very symptomatic. They can be short of breath. They can have palpitations. They can even get some chest tightness. And they're at risk for stroke, which is the really terrible thing about it. That's why diagnosing it and treating it is very important.
This might be a little off subject, but not really, because I'm going to ask you all to, both of you, we'll start with you, Dr. Chaleff. The patients come in and they go through their what I would call their cardiovascular checkup, or they were referred to you by a colleague, whatever. Are there discussions about nutritional intake and hydration and exercise?
Yes, we do talk about exercise. We talk about diets, talk about the Mediterranean diet. We talk about how much total fat and cholesterol they should have in their diet. If they're diabetics, how they regulate their sugars with their insulin or any medications that they may take with their endocrinologist. But yes, lifestyle modification is something we emphasize all the time in many respects when they come in. And we try to be more proactive about that as well. And that's the first thing we do with cardiovascular disease is really address lifestyle modification.
Dr. Satija, do you have anything to add to that?
No, I think diet and exercise and lifestyle modification is very important, right? Patients are happier if you can tell them, I'm not going to give you a pill. I need you to do this. This is your homework. You're going to drink this amount of water. You're going to eat this amount and work with portion control or work with more of a Mediterranean diet. For me, I see a lot of older patients with dizziness and lightheadedness, passing out. And a lot of times hydration is an issue, especially here in Florida, because it is very hot during the summer. And a lot of my older patients, their thirst mechanism just isn't very sensitive anymore, and they don't drink enough water. And I think that's important. Now, obviously, aggressive hydration isn't for everybody. Some people have congestive heart failure or other issues where they need to restrict them. But certainly drinking enough water in someone who's otherwise healthy is very important.
Well, you know, it was interesting. I was talking to a colleague of both of yours just recently, and we were talking about cardiovascular hypotension. Do you see many people that have this cardiovascular hypotension?
I end up seeing a lot of patients who have issues with regulating their blood pressure. They drop their blood pressures when they stand. They get lightheaded and dizzy when they get up to go to the bathroom. It's not as common as high blood pressure. High blood pressure is the most common disease we treat, of course. But you definitely see it, especially in older patients, people with Parkinson's disease, people with other things in that family can really have issues with regulating their blood pressure. And especially in a geriatric population, that's something that can be very challenging.
Well, we're down to the last 3.5 minutes of this show, and I'm sure that we've answered a lot of the questions of the viewers. But let me just ask you both to tell these viewers how often they should be visiting their physicians for their checkups, and particularly cardiovascular and blood views. It's all yours.
Of course, it depends on the patient's comorbid medical problems, their age, their risk factors. We like to see patients sometimes 1 to 2 times a year, if not more frequent, depending if we're titrating their medications. If we're doing a routine screening Sometimes just once a year is enough. It just depends. But if we find any issues, the sooner we can respond to it and deal with it, like sending it to Dr. Satija or doing a stress test or whatever the case may be, it's a better outcome for the patient. And that's what we look for, best outcomes for the patient.
Great. Dr. Satya?
I think exactly what Dr. Chaleff said. I stress to all my patients over 40, every year, annual physical, you get an EKG, you get your cholesterol, your blood work checked, you get your fasting sugar checked for everybody. I think a good EKG for anyone over 40 is part of a physical exam. It is very important.
That's great. I really appreciate both of you. I know how busy you both are, but I thought that we had so many questions, and I think a lot of it has been people are afraid that something's happening to them, and they don't know what to blame it on, but yet it does. To me, it's a collaborative thought. In other words, now all of a sudden someone who possibly had no problems with the COVID, but they end up worrying about the rest of the things that they hear. So you've added a great deal of information, and I appreciate it. So, Doctor, you are cardiologist, electrophysiologist. I know you're at Northwest Medical Center. And Dr. Fred Chaleff, who is a cardiologist and an interventional cardiologist, and he's at HCA Florida Westside Hospital. Well, thank you both very, very much. We appreciate your time this morning. I know how busy you both are, although most of the people will be seeing these things in the evening. I just want to talk to the people who are watching. Remember, you've heard it. You've got to see your doctors. You can't just walk into a pharmacy or supermarket or whatever and say, oh, gee, I got a little indigestion, I got a little pain, I'm going to take something off the shelf. Whatever it is, it's fine to do that, but sometimes, but you have to get to speak to your doctors. You can't hold information back from your physicians. I always tell you, you got to take good care of yourself. And the way you take good care of yourself is communicating with qualified professionals such as Dr. Satija and Dr. Chaleff. So thank you once again for showing up to this show. We're shooting today for the first time from the Alan B. Levin NSU Broward Center of Innovation. It is a fantastic collaboration that we have here at Nova Southeastern University between University and Broward County, and I can tell you that it's the future. But what's important to me right now is your future. So if you have any questions, you have any comments, there's an address and an email right here. This show is called Dateline Health. My name is Fred Lippman. Until next time, see ya.